in lymphoma through advocacy, networking, and education. The chair of this group is Professor Judith Trotman from Australia, and she deserves an enormous amount of credit for putting this group together and really leading our first month as a group, our first year as a group. We are also indebted and grateful to the Snow Dome Foundation and to Anna Steiner, who leads our administrative team and really keeps us in place and moving forward. So this lecture series is our second one. In September, there was a diffuse large B-cell lymphoma lecture series that was incredibly successful, and based on that, we decided to, this month, focus on lymphoma. So it's truly an honor to be introducing our two speakers tonight, Dr. Margaret Shipp and Dr. Ranjana Advani, who will be speaking on harnessing the immune system to treat Hodgkin lymphoma. These two are incredible luminaries in the field who really need no introduction, and to whom I'm personally indebted as they are role models and really mentors for me and for many. I'll introduce Dr. Advani after Dr. Shipp's talk, and we will hold questions until the end so we can really give them a chance to give their talks. So I'd like to introduce Dr. Margaret Shipp. She is the Chief of the Division of Hematologic Neoplasia and the Director of Lymphoma Research Center at Dana-Farber Cancer Institute. She is a Professor of Medicine at Harvard Medical School. She did her internal medicine training at Washington University in St. Louis, and then was a fellow at Dana-Farber Cancer Institute, where she subsequently joined the faculty. Her research interests include the characterization of comprehensive molecular signatures, survival pathways, and associated rational therapeutic targets in diffuse large B-cell lymphoma and also classic Hodgkin lymphoma. She has won numerous awards, including being designated as a Leukemia and Lymphoma Society American Stolman Scholar. She is also a Doris Duke Distinguished Clinical Scientist and is a member of the American Society of Clinical Investigation, the Association of American Physicians, and the Institute of Medicine. And we are thrilled, Margaret, for you to start us off tonight.
Well, thank you very much for that kind introduction. It's really a treat to be here tonight, and it's also very special to me to actually give this talk in association with one of my very good friends and colleagues, Ranjana Advani. So we'll go ahead and get started. Anna, it looks like, hang on a minute, let me see if I can share these now. Okay. Can you see my screen?
We can, yes, thank you.
Okay. So what we're going to be talking about today is harnessing the immune system to treat Hodgkin lymphoma. These are my disclosures. And as this group knows very well, classical Hodgkin lymphoma is an unusual lymphoid malignancy in which the primary tumors contain very small numbers of the malignant Reed-Sternberg cells that are surrounded by an extensive T-cell rich inflammatory immune cell infiltrate. But despite that, until recently, there was really very little evidence of an effective anti-tumor immune response. Work a number of years ago from our group and others identified a genetic alteration in Hodgkin's lymphoma. It was a recurrent copy gain of chromosome 9p24.1, which was interesting with regard to the idea of an immune response in Hodgkin lymphoma because it is the locus for both of the PD-1 ligands, PD-L1 and PD-L2, and also JAK2. And the reason this is interesting is JAK-STAT signaling is an additional mechanism of upregulating the PD-1 ligands. And so as a consequence of this, we were very interested in understanding more precisely how often this genetic alteration occurred in classical Hodgkin lymphoma, and developed a FISH assay that allowed us to capture the copy gain in Hodgkin lymphoma and actually quantitated in a range from polysomy through copy gain to amplification, and then to identify the overexpression of the PD-1 ligand PD-L1 associated with the magnitude of copy gain. And in a collaboration with Ranjana's group at Stanford, we actually looked at the incidence of the 9p24.1 copy number alterations in a series of 108 patients who had been treated with state-of-the-art combination chemotherapy. And what we found was that almost all of them, 107 out of 108, had these 9p24 alterations. So it really seemed to be a near universal finding in Hodgkin lymphoma, and raised this interesting idea that it could be a genetic basis for sensitivity to PD-1 blockade. The other thing that we found in the context of this study in collaboration with Ranjana's group is that the magnitude of 9p24 alterations was associated with outcome just to standard induction therapy. And those patients that had the highest levels of 9p24 alteration actually had the least favorable progression-free survival. And consistent with this, and consistent with the notion that classic staging is also of adverse significance, we found that there was the highest incidence of amplification in patients with advanced stage disease, and I'll come back to why that's relevant. And Ranjana will talk about this in more detail in the second half of the talk, but what we quickly went on to do in collaboration with many colleagues around the world is to actually evaluate the efficacy of PD-1 blockade in patients with relapsed refractory Hodgkin lymphoma, and found that there was about a 70% response rate in this patient population with PFSs of around 15 months, and a subset of patients who had durable complete remissions. And so that led us to ask about prognostic indicators of efficacy to PD-1 blockade. And we applied the same FISH assay in the registration trial of nivolumab in patients with relapsed refractory Hodgkin's, and found the same sort of distribution of the 9p24 copy number alterations, and a very highly significant association between the copy number alterations and the expression of the PD-L1 ligand. And this had predictive value in the context of the clinical trial. Those patients who had the lowest level copy gain and the lowest level PD-L1 expression actually were least likely to do well using PFS as a parameter of outcome. And so the reason that these findings were of interest in terms of thinking about next steps in Hodgkin lymphoma is they really provide a rationale for upfront therapy of Hodgkin lymphoma as well. As everyone knows, advanced stage disease is associated with inferior outcome to standard induction therapy. We found that the 9p24 copy gains were associated, the highest level copy gains amplification was associated with unfavorable outcome to standard induction therapy, that the amplification was more common in advanced stage patients, and also that there were more favorable responses to PD-1 blockade in patients with relapsed refractory Hodgkin's who had high-level 9p24 alterations and increased PD-L1 expression. So putting all this together, it really resulted in a compelling rationale for actually evaluating PD-1 blockade in the combination with standard induction therapy for patients with newly diagnosed advanced stage disease. And Ranjana will talk about that in the second half of the talk. In addition to looking at this type of modality in induction therapy, increasingly it's been incorporated in treatment at first relapse and also consolidation of stem cell transplantation. So we've also been very interested in trying to understand mechanisms of response and resistance to PD-1 blockade in Hodgkin's lymphoma. And I've already mentioned the 9p24 alterations in PD-L1 expression, but there's additional emerging data that suggests that there may be important findings with respect to alterations in antigen presentation machinery, and also the types of cells that are involved in the immune response to PD-1 blockade. And I'd just like to mention some of that data now. The 9p24 alterations are not the only genetic alterations that convey an immune evasion phenotype in Hodgkin's lymphoma, we know that there are frequent inactivating mutations of beta-2 microglobulin, which limit the expression of MHC class I on the cell surface. There's also copy loss of MHC class I that limits the expression of MHC class I on the cell surface, and also some genetic alterations that limit the effective presentation of MHC class II as well. And so this prompted us, also in the context of the registration trial for nivolumab, Checkmate 205, to actually ask about the levels of expression of beta-2M and MHC class I and MHC class II on the Reed-Sternberg cells. And what we found was that the vast majority of patients' tumors lacked MHC class I expression. So less than 10% of the patients in this trial had MHC class I expression on their tumors. And so this is a good example here. This is a blow up of the Reed-Sternberg cells, and you can see the absence of class I expression in comparison to the normal infiltrating lymphocytes. And here's another example of that. And a smaller percentage of patients had Reed-Sternberg cells that lacked MHC class II expression also. There wasn't an association between these two parameters. This is an example here of a tumor that lacks MHC class II but has MHC class I expression. And so what this says, and the reason that it's relevant in terms of thinking about the mechanism of action of PD-1 blockade, is it says that tumor antigen presentation by MHC class I to CD8 cytotoxic T cells is unlikely to be playing a major role in the efficacy of PD-1 blockade in Hodgkin lymphoma. And in fact, that was true in Checkmate 205, but what we did find was that there was a highly significant difference in outcome, again using progression-free survival as the parameter, in patients whose Reed-Sternberg cells expressed MHC class II in comparison to MHC class I. And the reason that that's relevant is it really makes you think about mechanisms of action that are dependent on MHC class II mediated antigen presentation. And here, the T cells that would recognize MHC class II are actually the CD4 effector cells rather than the CD8s. And so this prompted us to actually look at this in more detail using a combination of imaging and CyTOF analyses. And so in work that we did in collaboration with Scott Rodig's group, we looked at the immune infiltrate in the intact tumor microenvironment and saw that there was a striking enrichment of CD4 T cells in immediate proximity around the Reed-Sternberg cells. And you can see this is multiplex immunofluorescence, so you can digitize images for thousands of cells on multiple patients and assess statistical significance. And so what you can see here is that there's this is a distance metric, so this is physical interaction with the Reed-Sternberg cells. These are in close proximity, and these are far away. And so what you can see is that there's a clear enrichment for CD4 positive T cells, both PD-1 positive and PD-1 negative, in the immediate proximity of the Reed-Sternberg cells. And this was not true for CD8s, so there was no enrichment whatsoever for CD8s. So this was an additional piece of evidence that really spoke to CD4 T cells playing an important role. There was another interesting finding, and that was that there was an additional population of cells that existed in proximity to the Hodgkin Reed-Sternberg cells, and these were tumor-associated macrophages. And I've shown the digitized image here, but we think about this almost as a castle and moat phenomenon. The tumor-associated macrophages that were in close proximity to the Reed-Sternberg cells were selectively positive for PD-L1 as well. And so this is an additional group of cells that can function to limit the efficacy of T cells in this neighborhood by engaging PD-1 receptors on T cells. And so we think about this as the genetic upregulation of the PD-1 ligands on the Reed-Sternberg cells themselves, but an additional level of protection that's from the macrophages that are also PD-L1 positive. To understand more about the tumor microenvironment, we developed a CyTOF assay. This is an approach that allows you to heavy metal label a whole panel of antibodies, 40 different antibodies at the same time, and to, as a consequence of that, be able to evaluate multiple parameters of T cells, lineage, differentiation, polarization, and functional status, in addition to capturing aspects of function and markers of Reed-Sternberg cells themselves, NK cells, B cells, and macrophages. And the take-home point from the initial study, looking at the tumor cell suspensions from a series of patients with newly diagnosed Hodgkin's lymphoma and comparing them to cell suspensions from reactive lymph nodes and tonsils, was that there was a highly significant enrichment of both the Th1 polarized CD4 T regulatory cells and the Th1 polarized CD4 effector cells. And we could look, because PD-1 was one of the markers that was in the panel, to look at the levels of PD-1 on these effectors. And what we saw was that these enriched CD4 effectors were positive for PD-1, but that the T regulatory cells were negative for PD-1. So basically what you have is an enriched microenvironment for the exhausted CD4 T cell effectors and the functionally active T regulatory cells. So it's two different complementary mechanisms for CD4 T cell dysfunction in Hodgkin lymphoma. And so we went on to understand this in a little bit more detail, again, coming back to the peripheral blood mononuclear cell samples that had been obtained in the context of the Checkmate 205 registration trial. And we did a couple of things in parallel. One was to perform T cell receptor signaling of the peripheral blood mononuclear cells as a whole, and also the CD4s and the CD8s, and then to additionally do the same sort of CyTOF analysis of the CD3s, CD3 positive T cells, and the CD3 negative immune cell subsets. And we also included healthy donors and patients with newly diagnosed Hodgkin lymphoma as a comparator. And one of the first things that we did looking at the T cell receptor signaling was essentially use a parameter of T cell receptor diversity. And that is shown here on the y-axis. So essentially what this reflects is how many different specificities there are clones that are capable of recognizing in the baseline T cell receptor repertoire. And focusing initially on the comparison between healthy donors and patients with a newly diagnosed disease and patients with relapsed refractory disease, what you can see is that even at diagnosis, before patients have been treated, they have a highly significant decrease in their T cell repertoire diversity, meaning they have less capability of recognizing a diverse pool of antigens. And then at the time of relapsed refractory disease, this is even worse. And this is like, and at that point, it's likely a combination of both the disease itself and also the treatment of the disease. We also found that if you split out these patients who have relapse refractory disease based on how well they responded to their subsequent PD-1 blockade, you also saw that those patients who had less favorable responses, so these are patients who only achieved a PR or who actually had progressive disease, they had significantly lower TCR diversity in comparison to patients with newly diagnosed disease, whereas the patients who had the best responses to PD-1 blockade, so the complete responders, actually looked much more like patients with newly diagnosed disease. And then because of this emerging story regarding a selective role for CD4s in the response to PD-1 blockade, we performed the same sort of analysis in highly purified CD4 T cells and CD8s. And what you can see here is exactly the same sort of pattern in the purified populations. But the next thing that we were able to do was to actually look at diversity over treatment. So looking at a pre-treatment sample and then a sample at the day one of the fourth cycle of nivolumab therapy. And these results were interesting. What we found was that there was a selective increase in repertoire diversity only of the CD4 cells, and that there was not any change in the CD8 T cells. So this is really some of the first definitive data that there may be a specific role of PD-1 treatment on actually the CD4 T cell immune response. The other thing that was interesting about this is that this CD4 selective response was most striking in patients who achieved the best responses to therapy. So again, in this subset of patients who achieved complete responses, really providing further evidence that this selective effect on CD4s was beneficial with regard to efficacy of PD-1 blockade. The next thing that we did was actually ask about selective expansion of T cell clones using the TCR sequencing. And I think here it's actually useful to think about this as a cartoon. And so you can have at the beginning of therapy clones that are already expanded, and so those are shown here with multiple representations, or at the beginning of therapy not expanded, and then you treat with PD-1 blockade, and then you can have clones that were not expanded at baseline that then become expanded, clones that weren't expanded at baseline and didn't expand, or you had ones that were expanded at baseline and expanded further, or really stayed the same. And the reason this is relevant is by knowing these different parameters, you can specifically characterize the clones that expand in a specific response to PD-1 blockade. So we did this with over 4 million TCR sequences, and almost 800,000 expanded at least twofold following PD-1 blockade. So it raises the likelihood that at least a subset of these are in response to PD-1 blockade. And so what we found, and I'll sort of cut to the most important point here, is that when we look at expansion of these clones, we found that the ones that were most closely associated with a response to PD-1 blockade were actually what we call the singletons in comparison to the non-singletons. And so the interpretation of this is that this is expansion of less terminally differentiated T cells that are associated with a more favorable response to PD-1 blockade. And the reason this is also interesting is that if you look at the entire spectrum of differentiation in patients with relapsed refractory Hodgkin lymphoma, this is relying on our CyTOF data, what we see is a skewing of the T cell repertoire. So in comparison to patients, in comparison to either healthy donors or patients with newly diagnosed Hodgkin's, these patients with relapsed refractory Hodgkin's lymphoma have more of the terminally differentiated PD-1 positive effectors in comparison to patients at these earlier stages of differentiation, and fewer of these less mature clones. And so putting this in the context of our emerging understanding of PD-1 blockade is actually important, because what these data do is argue against the notion that PD-1 blockade works by reinvigorating terminally exhausted, differentiated T cells. And this has really been the dogma until the last couple of years. But there are emerging data that support the notion that PD-1 blockade is actually working at an earlier time point in T cell differentiation. For example, there's earlier work suggesting that by the time you get to be a terminally differentiated, exhausted T cell, you really have very little capacity to respond to PD-1 blockade. And part of that is because you have a fixed epigenetic profile. And then there's also data from several sources in different experimental model systems and tumor types, again suggesting that PD-1 blockade is working and that there's an importance of T cells at an earlier time point in differentiation. And there's additional more recent data in patients with solid tumors. This is particularly in melanoma and a couple of other solid tumors, to suggest that responses to PD-1 blockade are actually more dependent on the recruitment of novel T cell clones rather than the further expansion of previously identified tumor-specific T cells. And this is, we think, interesting, particularly in Hodgkin's, because our genetic analyses of Hodgkin show that this is a tumor that has an extremely high ongoing mutational burden. And so with this and the T cell rich inflammatory infiltrate, you can imagine that PD-1 blockade is actually facilitating T cell responses to new neoantigens. And so finally, just a couple of other points that emerged from this recent analysis. We also were able to look at the CD3 negative populations in patients with Hodgkin's lymphoma. And here, the question really is the whole story around T cells, or are there other populations that are likely contributing to the immune response in Hodgkin lymphoma? And so this is just the type of output that you see with the CyTOF analysis. But this is the more important data, which is just the summary of the different cell populations that you see across the comparisons, healthy donors to newly diagnosed to relapse refractory. And it's probably easier just to see this as simple bar graphs, which is what's shown here. The majority of the CD3 negative population is made up of monocytes and B cells and NK cells. And the reason that I bring this up is that there are some striking differences in the abundance of these populations. Again, first off, between healthy donors and patients with newly diagnosed Hodgkin's. So if you look at the composition of this infiltrate, which is monocytes, B cells, and NK cells, what you see is that in patients with newly diagnosed Hodgkin's, before they've received any treatment, there's a highly significant decrease in circulating B cells, and probably more important in terms of thinking about additional cytotoxic effectors, there is a dramatic decrease in the percentage of NK cells, and this is across all stages of NK cell differentiation. And so this really suggests that there are additional populations that warrant some further evaluation. And in looking at in the relapsed refractory space, and again seeing are there associations with the subsequent response to PD-1 blockade, you see that the abundance of B cells, circulating B cells, and also importantly, the abundance of circulating NK cells of the most mature phenotype that would be the effector cells is associated with response to PD-1 blockade. So the reason that the NK cells are particularly important, as you likely know, is that NK cells are particularly effective in mounting responses to cell types that lack MHC class I. And the reason is because there is an inhibitory receptor on NK cells that engages MHC class I and shuts down activity. So in settings where you lack MHC class I, NK cells may be particularly important. So these deficits of NK cells in Hodgkin's lymphoma, which is a class 1 negative tumor, are likely to be particularly relevant. And then just finally, one last point is that we've also identified other effector populations that may also be playing a role outside typical CD8 cytotoxic T cell responses. There is a population that we call killer macrophages that express granzyme B that are less abundant in patients with newly diagnosed Hodgkin's and have this response relationship that we can also go back in relapsed refractory Hodgkin's and find in the tumor biopsies themselves. And in the relapsed refractory setting, they actually constitute about 12 to even 20% of the granzyme B positive putative cytotoxic effectors. So just finally, in terms of thinking about these last lessons from the periphery, there are highly significant defects in the peripheral immune signature in patients already with newly diagnosed, previously untreated Hodgkin's. PD-1 blockade is most effective in patients with a diverse baseline TCR repertoire and an associated expansion of clonally diverse CD4 T cells during treatment. The patients with most favorable responses to treatment also had a CD3 negative peripheral immune signature, increased B cells and K cells, and these interesting newly identified innate effectors that were more like those of healthy donors. And so we really think that these studies together reveal complementary roles of the newly expanded clonally diverse CD4 T cells and innate effectors in the response to PD-1 blockade. And then I think probably most important is to acknowledge the many people who really participated in aspects of this study. And I want to particularly acknowledge some people from my laboratory, Zuma Cater, Kirsty Winan, Kyle Wright, Julia Pakowska, Jing Wang, Elisa Mandato, Bjorn Chapui, and Marit Romer for their contributions to this work. And also this has been done long-time collaboration with Scott Rodig in hematopathology and Philippe Armand in clinical lymphoma, and also our collaborators in computational biology, both at the Dana-Farber, Shirley Liu's group, and at the Broad Institute, Gadi Getz group. And it's also my pleasure to hand off to my colleague and collaborator and friend, Ranjana Advani, for the second part of the talk.
Thank you so much. That was really such elegant and interesting data. And when we get to the end, hopefully we'll be able to have some questions that kind of bring together the two aspects of these talks. So I'd like to introduce Dr. Ranjana Advani. She is professor of medicine at Stanford University, specializing in lymphoma. She holds the Saul Rosenberg Endowed Chair. Her primary research interests include Hodgkin and non-Hodgkin lymphoma, optimizing frontline regimens, and also developing novel and targeted agents in the relapse and refractory settings, also working on correlatives and biomarkers. She has led numerous international studies as a primary investigator and has published extensively in the field, and serves as a member of multiple important committees, including the Eastern Cooperative Oncology Group, the NCCN Guidelines, and has also served as a co-chair of the National Cancer Institute Lymphoma Steering Committee. Ranjana. Oh, I think you're muted.
Okay, I can finally unmute. I wasn't able to unmute. All right, so I'll just share my screen. Thank you, Anne, for that introduction, and Margaret too. I can tell you it's been absolutely lovely working with Margaret on this. I've learned so much from her about Hodgkin's biology, which I had never even thought of. And it's just been an amazing experience. And let me just get to the sharing screen. Hang on just a second. One second. Can you all see my screen?
Yes, it's coming.
Okay, there we go.
Perfect.
So I'm going to focus on the clinical aspects of a lot of it was based on all the lovely work which Margaret did and has walked over so elegantly. And right now we know that the approved novel agents are basically the brentuximab vedotin and then the checkpoint inhibitors. And for the purposes of this talk, I'm just going to focus the clinical work which has been done with the checkpoint inhibitors. And I'm not going to go into the biology anymore because no one can explain it better than Margaret just did. But the efficacy of the approved checkpoint inhibitors, nivolumab and pembrolizumab, this audience is quite familiar with. They were both tested in the relapsed or refractory setting in many patients who had even failed transplant. Some of them had failed brentuximab. And they both have a very high individual response rate in the 70 to 80%. But the CR rate of single agent is anywhere from 16 to 25%. And the progression-free survival for both the agents is approximately 15 months. And of course, deeper responses as you continue patients on treatment. So the question comes, well, which is better? Is like the checkpoint inhibitor better than BV, and what should we be doing clinically? So recently the Keynote 204 trial was presented and published, which actually just compared brentuximab versus pembro in patients who were ineligible to get a transplant or those who had relapsed after a transplant. And the patients were BV naive, and they said that BV exposed patients were eligible, but that was only a minority. I think there were just about 5 patients or so. But so in essence, these were patients who had never had BV, and they compared it to pembro. And you can see the treatment-related adverse events. It's what we expect. With the brentuximab, the neuropathy is the issue, and then with the pembro, it's the hypothyroidism, the pruritus, and the fatigue. And there weren't really major immune-related reactions which were beyond what we would expect. But the overall response rate was in favor of the pembro arm with the 65.6%, despite an equal CR rate in about 24% in both. So same CR rate, but much better overall response rate and progression-free survival. And it worked in almost every subset. It was better than BV. So it worked whether you were primary refractory, relapsed within 12 months, relapsed after 12 months, and whether they'd had prior BV or no. And as I said, the number of patients who had prior BV was pretty small. So with that as a background, these agents are, of course, now moving quickly into various aspects of treatment. So it's moving into frontline for early stage. There are ongoing studies to define its potential to reduce the number of cycles of chemotherapy or maybe get rid of radiotherapy. For advanced stage, how do we improve upon the results with ABVD or even now brentuximab ABVD as second-line therapy in combination with chemotherapy or just the novel agents by themselves, and post the maintenance question, and then some data on other emerging therapies once they've failed all these therapies we know, and especially post-transplant. So the first trial I'm going to touch on in early stage unfavorable classic Hodgkin's lymphoma is the NIVAL trial by the German Hodgkin Study Group. And this actually asks a simple question of combining nivolumab with AVD. And this was a comparison of sequential versus concurrent dosing. And there were 4 cycles, and at the end of the therapy, they all got radiotherapy. But if you look at the remission status, and you can see just whether you gave it concomitantly or sequentially, the CR rate was pretty high, but concomitant was slightly higher. And the progression-free survival in both is excellent. Then the median follow-up was pretty short, but nonetheless, at 14 months, it looks like this certainly is a approach. And if the CR rate is high and you have a very good progression-free survival, I think the next logical question is, can you drop the radiotherapy? That's not addressed by this trial, but that is being tested in other trials. The other recent update, which was just presented on this trial, was apart from, when you look at the decrease in tumor burden, when you compare nivolumab AVD ×2 versus just Nivo by itself, it's impressive that just Nivo by itself as a lead-in before you actually gave AVD also results in a fairly significant reduction in tumor burden. And if you look, they did this interesting analysis where they looked at the spread of the sum of the products compared with metabolic tumor volume versus and tumor lesional glycolysis, which are these other correlates of PET which are being used. And if you look at that, it looks like the they compared the standard definition of some of the products, which we use for response criteria, and they looked at the MTV and the TLG. And with the nivolumab in combination with chemotherapy, the differences were quite significant in compared to the standard definition, where you get much more reduction in the delta MTV and TLG, actually in both, in whether you gave it in combination or whether you gave nivolumab alone. So just even nivo alone has a dramatic response, but when you combine it with chemotherapy, it looks like the definition of a metabolic CR can be further defined, and it certainly appears to be more accurate than the traditional sum of the product definition which is used. So the conclusion on that was it leads to rapid near complete reduction of tumor metabolism. So these PET-derived biomarkers might allow reduction or even omission of chemotherapy and radiotherapy. So I think these results were quite provocative to test this in trials moving forward. Now the Northwestern did another trial where they used actually pembro as a lead-in for 3 trials. And the primary endpoint was the PET2 negativity rate after the pembro 3 doses. And then patients got ABD, and depending on whether they had early stage or advanced stage, they got anywhere from an additional 2 to 4 cycles to a total of 6 cycles. And what was interesting was that just pembro monotherapy, there was a 37% CR rate, and then everybody else, once you added chemotherapy and end of therapy, all the patients did extremely well, and you can see the progression-free survival at 22 months is 100%. And this is just an example of 2 scans where these were scans done after 3 doses of pembro. So this is very bulky disease, and you can see that this one tiny area was left over here, which was read out as a Doble 4, but in reality, this was amazing impressive results with just 3 doses of pembro. And similarly, in this other case over here, you can see that after pembro alone, you just have this little rim left over here, suggesting that the checkpoint inhibitors are very potent drugs in the frontline therapy and offer us the opportunity to study the next step of, can we get rid of chemotherapy, or can we get rid of radiotherapy, or reduce the number of cycles? So in advanced stage, I think Margaret alluded to this trial where the Checkmate 205 looked at the combination. There was a nivo lead-in, but then it was combination of nivo with AVD. And at a median follow-up of 11 months, you can see that the progression-free survival was 94%. Again, at the end of therapy, there was a overall response, the CR rate. There was some patients achieved a CR, which was much more at the end of therapy. The overall response rate went up to 84%. And it's interesting when you look at the difference between the investigator reported rates versus the independent review committee. It's higher by the investigator reported rate, because we know if you use the lyric criteria when you use checkpoint inhibitors, that not all progressions are true progressions. And if clinically the patient is responding, they actually can continue on treatment. And I suspect that discrepancy of, let's say, 51 to 71 is likely that, and 67 to 80. But nonetheless, very provocative. And this has led to the basis of the ongoing US intergroup trial, which is comparing nivolumab AVD to brentuximab AVD for patients with newly diagnosed stage 3 and 4 Hodgkin's lymphoma. Now, when patients relapse, the standard of care is getting them to transplant. And the pre-transplant PET is one of the most consistent prognostic factor for relapse or refractory disease, that patients who go into transplant with PET negative disease have much better outcomes than patients who go into transplant with PET positive disease. So the goal is to salvage them with a regimen which has the highest chance of getting them to a PET negative state. And that traditionally has been chemotherapy, and we've all been using ICE or GND or DHAP. And the standard with these second-line therapy chemotherapy options are similar, and the PET negative rate with the chemotherapy is anywhere from 50 to 60%. But it is chemotherapy. Patient gets cytopenias. Most of these are given as inpatient regimens. At least at our center, ICE and DHAP cannot be given as an outpatient. We do it as an inpatient. GND can be done as an outpatient, but it is chemotherapy. And these patients are typically young, and for their transplant, they are going to be in the hospital getting more chemo. So the premise is, how can we make at least part A, when we're giving them their first salvage, a little simpler? So there have been lots of studies combining brentuximab with chemotherapies. And Anne led a study looking at brentuximab with bendamustine, again with a high CR rate of 74% and 2-year progression-free survival of approximately 60 to 70%. And that's kind of been the case across the board when you add these novel agents, brentuximab to chemotherapy. The trials are not that mature, but approximately the PFS is anywhere from 60 to 70%. And we're adding brentuximab to chemotherapy, there is some increased toxicity, some more immune-related reactions, and the chemotherapy part is still the chemotherapy part. I mean, it's not significantly worse than by adding brentuximab, but it doesn't simplify it. So that led to looking at a combination of brentuximab and nivolumab as first salvage. And this was published at a follow-up of about a year where you can see that the overall response rate is 82% with a CR rate of 61. And just to remind you that with each individual agent, whether it's brentuximab or nivolumab, the CR rate of these drugs as individual agents is not more than 30%. With BV, it's about 30%. With nivolumab, it's slightly lower, anywhere from 18 to 24, depending on the study. So this looked like combining the two led to doubling of the CR rate. So more patients were able to get to transplant with PET-negative disease. And in this trial, patients got 4 cycles of BV-Nivo as first salvage and then proceeded to transplant if they had a good response, defined as an excellent PR or a CR. And for the patients who actually went to transplant in a CR with just 4 doses of BV-Nivo, at 2 years, their PFS is 97%. And at further follow-up, I think the most recent cutoff, it's come down a little bit, but it's 94%. So still very, very good. And it's amongst the best results we've seen for salvage regimen. There were some immune-related effects, but that really didn't lead to too many study discontinuations because of that. And there was no problem collecting any stem cells. So we know that the checkpoint inhibitors as far as the PD-1 blockade, but there is another checkpoint which you can block, which is CTLA-4, and that can be blocked with ipilimumab. So ECOG is asking a different question, and they looked at, well, you can combine BV and Nivo, but what if we add ipilimumab to it? And so this doublet or triplet was studied, and Catherine Deffenbach led that study. And if you can look over here, the doublet and triplet are both active. And there was a sense that the progression-free survival at a very short follow-up was better for the doublet and triplet. And certainly patients who got BV-IPI didn't do well. So BV-Nivo did very well, and the triplet did well. So you can see the response rates over here. And this was not a first salvage. This was a different study population. These patients could have gone onto the study even after failing a autologous transplant. So it was asking a different question than the previous study I just showed you. But nonetheless, the triplet was active. So what is going on now is actually a randomized trial comparing BV-Nivo to BV-IPI-Nivo. It's a randomized phase 2 trial, and that's going on currently in ECOG. So Alex Herrera presented another approach last year at ASH, where again it was a PET-adapted approach, where it was Nivo-ICE, but there was a Nivo lead-in for 2 cycles, and after that they got imaged, and if they were in a CR or a PR, they got additional Nivo, and if they achieved a CR, they could go straight to transplant without any chemotherapy. If they had stable disease or progressive disease after the first interim scan, chemotherapy was added, and then they could go on to transplant. And what was really interesting was just after the nivolumab for 6 weeks alone, you could see that the overall response rate was 90%, with the CR rate of 58%. So again, this is just nivolumab alone as first salvage. So many patients went, so 29 out of these 43 patients actually went on to transplant directly without ever getting chemotherapy. So that was also very, very encouraging results. And if you can see that on this waterfall plot, that it's a very active way to treat patients with a median follow-up of about 12 months. The 1-year PFS is 74%. This is a follow-up though. So they found this unexpectedly high 70% response rate. So they're looking, we have to see the full publication, but this is certainly again asked the question, can we sort out patients who don't need a transplant eventually, and we can just keep them on a checkpoint inhibitor, and if so, for how long? Or is there any other parameter, maybe something like metabolic tumor volume or any of these other biological correlates or any other thing we can look at which might help us choose patients who need to go to transplant or not? So this year at ASH, Alison Moskowitz presented another approach looking at Pembro with the gemcitabine containing regimen. And again, this was as first salvage. And patients got 2 cycles of the combination. These are standard GND doses, and then they had imaging, and then they got a total of 4 cycles and went on to transplant. And you can see just after the first 2 cycles that the CR rate was really high, with just 92% with just after 2 cycles of chemotherapy. So again, much better than what we have seen with standard chemotherapy. Seems to be much higher than what we've seen with traditional brentuximab and chemotherapy-containing regimens. And with a median follow-up of 11 months, there were no progression so far, and the regimen was pretty well tolerated. I mean, you do expect with these regimens some amount of neutropenia and some mild immune effects, but there wasn't anything which made it much more scary to give than what we would normally expect with the Pembro or with GND. So again, very encouraging results. So in the next cohort, they've actually taken the bold step of saying, well, if you get a 92% CR rate, do we really need the transplant? And I should commend them to say that the trial design has actually gotten rid of transplant. And they're gonna do a Pembro GVD, and if patients are in a CR, they're gonna get Pembro maintenance and they're not gonna get any transplant. So I think this is really provocative, and that's where the future is, to see if we can get rid of transplant or we can actually just select a few patients where transplant might be necessary. So what about consolidation after transplant? So we know from the Athera trial that BV consolidation for high-risk patients showed a PFS advantage compared to placebo. Now this was a much older trial. CT criteria were used to define response, so it was a little, whereas these days we use a PET CT. Nonetheless, 85% had 2 risk factors, and the risk factors were, relapse within a year, extranodal site involvement, and so on and so forth. But if you look at, so Pembro, Philippe has published on looking at Pembro as consolidation as well. And compared to the Athera trial, using those criteria, 40% had 2 risk factors. Again, the 19-month overall PFS was excellent. It was 81%. And if you look at the Athera eligible patients, if you look at those criteria, if they had 1 risk factor, it was 85%, 2+ risk factors, 83%. So again, while this is not a head-to-head comparison with the Athera trial, certainly when you break it down by the risk factors, it's extremely encouraging with very high progression-free survival rates. So Alex then this year at ASH presented data on, well, we know that BV works, we know that Pembro works. Like, what about if you give the combination as maintenance? So this was now a small study, 59 patients, and you can see it was a mixture of primary refractory, patients who relapsed within a year, some had relapsed late. And if you look at the Athera risk factors, only a quarter of the patients had 3 or more greater factors. Most of them had 1 or 2 factors. And if you look at this, about half of them had prior BV, and about 40% had actually had a prior checkpoint inhibitor. So that's what made this quite interesting. And you look at the common side effects. Yes, you do see more grade 3 adverse events. You saw neutropenia in 30%, pneumonitis is 7%, LFT abnormalities in 5%. And about a quarter of the patients, there was early discontinuation of both BV and Nivo. But if you look at the response at about 19 months, the PFS is 92%. And you look based on the number of risk factors. For 1 or 2 risk factors, it's excellent. It's 93, 96%. And for 3 risk factors, 83%. But overall survival is excellent, 98%. So again, these suggesting that these are very active agents in the maintenance setting. Identifying who the right patient is to give this is important because there's no overall survival advantages yet in the Athera trial. Until a randomized trial is done comparing these with no maintenance, we won't know that answer. But at least given all what we know so far, none of the trials in relapse setting, in this setting have shown any overall survival advantage. So toxicity will be the main question which determines whether this is going to be any role after transplant or not. And I think if Allison's study works out where you don't even need a transplant, then I think all these maintenance strategies will go out of the window. So we've kind of focused on the existing checkpoint inhibitors, but there are other targets which also involve the immune system, and one of them is CD25. You have, I talked about CTLA4, and you heard from Margaret about the macrophage story, and we know that the CD47 is a don't eat me signal, which impacts the macrophage a pathway. And I'm just going to go on to some of the other trials which have been looked at and where some of the ongoing trials are. So of course, CD30 is also a target for CART, and that is also sort of undergoing investigation. So we know the mechanism of all of these. So I'm going to go on to deplete. When we talk about the harnessing the immune system, the first one I'm going to talk about is camidanlumab tesirine. I'm going to refer to it as CAMI, which basically is this antibody drug conjugate, which is conjugated to this PBD dimer, which cross-links DNA leading to cell death. And so there are two potential mechanisms of action. One is, of course, direct toxicity. About approximately 60 to 80% of the cells express CD25. And then the other one is depletion of this immunosuppressive microenvironment and changing the ratio of effector to and regulator cells. So this was, Alex presented an update at ASH this year. There was phase 1 and phase 2 data combined. So in the phase 2, the overall response rate, and these are now patients who have progressed after brentuximab and progressed after a checkpoint inhibitor. And this highly refractory population, the overall response rate is 31% with a CR rate of 38%. So again, when you have patients who failed everything, this is very encouraging data. Of course, everything comes with some toxicity. And the main thing of concern for this molecule was Guillain-Barré syndrome, which developed in approximately 6% of the patients. So prompt recognition is important. Also, like docetaxel, they can get fluid retention. So if you give them dexamethasone to prevent that, and skin rash and liver function abnormalities are the thing. But the most worrisome one is Guillain-Barré. But nonetheless, it's an extremely active agent. The phase 2 has completed accrual. 100 patients globally was the goal, and that has just completed accrual. I just wanted to show you one of my patients on this trial who had failed everything possible under the sun. You can see we could never get him to transplant. And while he still has disease, a Dovel score of 4, you can see it's significantly better. I mean, he was transfusion dependent when he started the trial, and we just had a hard time breathing and lying down flat. And even just after the first dose, we saw him 3 weeks later, he was a new person. So it was very encouraging to see this happening to this very refractory patient. So of course, the CAR-T has made its way into the Hodgkin's world because of CD30 being a positive. So there were 2 parallel studies run at Baylor and North Carolina, and this was like patients with a median of 7 prior therapies. So again, a very heavily pretreated population, again with very encouraging results of an overall response rate of 62% and a CR of 51%, and the PFS is 41%. So patients who got lymphodepletion did better than the ones who did not get lymphodepletion. And unlike the B cell experience, they didn't really see the horrible neurotoxicity with the Hodgkin's population. I don't know why, but again, these studies are ongoing and will probably provide us yet another drug to use. So this whole NK, Margaret showed you a slide on the role of NK. So this AFM13 is a bispecific tetravalent innate cell engager that activates NK cells and macrophages via CD16A, and it targets CD30. So in a preliminary study of AFM13 by itself in patients who'd had 6 prior lines of treatment, many of them had prior transplant and about a third had prior brentuximab, you can see that the disease control rate, which basically looks at CR, PR, as well as stable disease, was 60%. But if you stick to the overall response rate of CRs and PRs, it was just 23%. But there was in vitro data suggesting synergy with pembrolizumab. So that was what Nancy Bartlett ran the trial, and the overall response rate was much higher, 82% with a 42% CR rate. But they did have immune-related toxicity in 93% of the patients of all grades. the trouble I had understanding this paper was trying to figure out how much of the response was because of the pembro by itself. And rather than, I don't know what the contribution of AFM to the whole thing was. So I don't know where this is going to go. You've heard the CD47 story, activating macrophages in the tumor microenvironment. So CD47 is a don't eat me signal, which is overexpressed by many cancer types to evade the host immune system, evades phagocytosis. So magrolimab is this anti-CD47 antibody, which promotes phagocytosis, and it's been looked at mainly in Hodgkin's lymphoma. So what is the rationale in classic Hodgkin's lymphoma? So we know now that 47 is consistently overexpressed in Reed-Sternberg cells. And we also know that macrophages are abundant in the tumor microenvironment, and PD-L1 macrophages contribute to immune evasion. And an increased number of tumor-associated macrophages is also associated with inferior outcomes. And there is also data in vitro which shows that magrolimab synergizes with other monoclonal antibodies and also checkpoint inhibitors. So it provides the second eat me signal. So like in non-Hodgkin's lymphoma, we use rituximab to be the second signal. In Hodgkin's, you can think of using one of the checkpoint inhibitor. So based on a lot of preclinical work and some scientific rationale, which Margaret supported, we developed a concept and submitted it for a phase 2 trial, which we're going to do together with Margaret and the clinical investigators of the FABA, looking at a combination of magrolimab and pembrolizumab in patients with relapsed refractory disease who are checkpoint naive. So this is it's like a small study with 24 patients. The primary endpoint is CR rate, because we know with pembro alone, the CR rate is about 20–24%. So if we've set a lofty goal of doubling the CR rate to say that it's a useful approach, and of course the toxicity, but it has a lot of correlative studies built up into it. And I'm really excited to work with Margaret and Anne and the rest of the group at the Dana-Farber on this study. So the novel immunotherapies being evaluated at various aspects. Of course, our role as investigators is the many unanswered questions, which, how do we sequence these? How, once you've given them up front, how will they work later on? And of course, the cost implications. So there's a lot of work ahead of us, but I think the field has never been so exciting. So thank you for your attention, and we'd be happy to take questions.
Thank you so much. I think what we'll do is just do a couple of questions to respect everybody's time, but after those two amazing talks, we have to have at least a couple of questions. So first question for Margaret, we got two questions asking about the role of age. Does that influence your observations in what you're seeing in terms of the immune microenvironment and defects in the peripheral immune system?
Yeah, it's a really interesting question. And so because the median age of the population that we looked at, it's population young adults, it's skewed young. Although we did have some interesting findings regarding the T-cell diversity analysis, and they prompted us to actually go back and look a little bit more in the literature at what's known about TCR diversity. And there is a very clear association between age and TCR diversity. And it's interesting, particularly for this women's group, it seems to be predominantly in men. So older women do fine. Older men, TCR diversity goes downhill. And so you could imagine that to the point, to the extent that TCR diversity does seem to be important to have a diverse repertoire for response to PD-1 blockade, that could play a role at an older time point, particularly for men as opposed to women, based on the demographics of the observations about TCR diversity so far.
That's fascinating. And then Ranjana, a question for you. Are you observing later use of platinum or standard salvage regimens as novel therapies are being used more often in first-line salvage and upfront? And I think sort of a follow-on question, with these very expensive therapies, do you think there's still a role for ABVD or, standard chemotherapy upfront in low-risk patients?
So, so the first question, are we seeing a shift towards using platinum later? I think it's variable still. I'm not seeing it consistently. So the way I look at it is if patients have relapsed like more than 6 months out or more than a year out, or they're not, and they don't have primary refractory disease where they've just blown through ABVD, especially if we see somebody relapsing a year later, we still use this traditional chemotherapy salvage and then take them to transplant. If, however, somebody is refractory or has relapsed very quickly after ABVD, that's the group which we are tending to use more of the novel agents. Now, regarding even within the novel agents, we've luckily always had, we have the ECOG trial open now. Before I had the company BD-NIVO trial, so we've been putting them on trial. But off trial, if somebody is not, if they've relapsed very quickly, we are tending to use the BD-NIVO combination, trying to get them to transplant. I find a lot of people in the community using what Anne published, BD-BENDA, because it's all outpatient and much easier. So they tend to be using that a lot more than the standard platinum salvage. The second part of the question about frontline therapy, I don't think, I still don't use BV-AVD for every single patient. I use it for the high-risk patients. Otherwise, I use the RATHL approach for patients with advanced stage disease, especially if they have an IPS of 0 to 2. The low IPS patients, I tend to just use the standard RATHL approach. The higher risk patients, definitely, I would use something else.
Yeah,
right now,
absolutely.
Trial. So.
Yeah, yeah. Well, that's great. I think since we're over by about 5 minutes, I'll take this opportunity to really give great thanks to Margaret and Ranjana for really exceptional talks. I think this is a field that is just exploding and so exciting, and hopefully we've increase the excitement about from some of our younger colleagues about the field of Hodgkin lymphoma. I'd also like to thank our sponsors, MSD and Roche, for their support of the WILS education in lymphoma, and wanted to bring to your attention our next talk. We have talks the next 3 weeks, and then there'll be a short break, and then we have one final talk. But the talk next week is Advances in Radiation Oncology with 2 leaders in that field in Hodgkin lymphoma, Dr. Debaja from MD Anderson and Dr. Gasparadowicz from Princess Margaret in Toronto. So we hope you'll join for those, and thanks so much to everybody for joining.
Thanks, Anne.
Thank you.
Thank you.